Good evening and welcome to the OCULUS seminar this evening entitled Creating Efficient Workflow with On-Demand Perimetry. Thank you for joining us. Our presenters this evening are Dr. Jim Hale. Dr. Hale is an optometric physician practicing in a multi-location group in Oregon. Dr. Hale provides comprehensive vision and eye health care with a focus on medical eye health issues, including dry eye syndrome, glaucoma, and macular degeneration. Dr. Hale lectures on the topic of dry eye syndrome and has written multiple articles on dry eye and glaucoma care. Welcome, Dr. Hale.
Thank you.
Joining Dr. Hale tonight is Brandy Cherry. Brandy is the clinic manager of Valley Eye Care in Corvallis, Oregon, and Brandy will also be presenting a little bit of the technician's perspective of creating efficient workflow with on-demand perimetry. So welcome, Brandy.
Thank you.
So as Dr. Hale and Brandy Cherry speak this evening, please look on your little GoToWebinar corner there and make sure that as you have some questions for Dr. Hale or Brandy Cherry, please go ahead and list those there. We will try to get to those at the Q&A session at the end of the seminar. So with that, without further ado, let's talk about creating efficient workflow with on-demand perimetry and Dr. Jim Hale.
Well, thank you, William. I appreciate the opportunity to be here. We're pretty excited about integrating on-demand perimetry into our office. So the first thing I wanted to bring up and describe was just kind of how we did this process before. Before on-demand perimetry, we used kind of the typical optometric model where we would identify a potential problem during a comprehensive vision exam. We would schedule that patient to return to the clinic for diagnostic testing. At that point, we were using a industry standard visual field unit. The system worked pretty well, but it had some shortcomings. So what we found is that, with our schedule being very busy, booking out about a month, oftentimes it took a while to get those patients back in. And in the case of glaucoma, in the case of a potential neurological condition, that was pretty nerve-wracking for the patient, but it also exposed us to some potential risks along the way. So, delaying the diagnosis for a month isn't always the best idea from a medical legal standpoint either. Another challenge we had was that in our clinic, at least, about 15% of the time when patients were scheduled to come back for visual field, they just didn't come back. They canceled, they no-showed, they were just lost to follow-up. And I always kind of felt like that was a real negative impact on the patient care that we were delivering. And I also felt that I had increased medical legal liability from the failure to diagnose. On the business side of the equation, it also reduced productivity for the business. So patients that didn't come back for those visual fields, we lost that productivity. Even just delaying it for a month delayed the revenue cycle as well. So from a medical standpoint, it worked okay, but it wasn't ideal. From a business standpoint, it definitely wasn't the optimum situation. So we're really glad to have moved on to the on-demand perimetry model. The way that the on-demand perimetry model works in our office is that, well, first off, I guess Brandy, my clinic manager, and I were at a demonstration of the Smartfield unit, and we just really liked it. We thought it had a lot of benefits to our patients, that it would add some value. So we decided that really the best way of bringing it to our clinic was to figure out a way of having it pay for itself. At the time, we had a fully functional FDT. We had a visual field, a standard Humphrey that was working great. So we didn't really need a third visual field instrument, but the advantages to this machine were so obvious that we brainstormed for a couple weeks to try to figure out how to make it work. Had our machine been broken, it would have been a no-brainer from a return on investment standpoint. But as it was, what we decided to do was implement on-demand perimetry. And basically the way this works is that we identify a risk during a comprehensive eye exam, like always. And at that moment, we order a visual field test to be performed. So it could be an elevated IOP, could be a visual field defect on an FDT screening. A number of other conditions might trigger an on-demand visual field, but it just happens that day instead of a month down the road. So when I identify those risk factors, I let the technicians know and they start their process. I move on to my next patient. They perform the Smartfield, which takes just a few minutes. And then I jump back into the room and finish with the patient. Generally, at that point, when I step back into the room, there's a paper printout of the visual field, like people may be used to with the Humphrey, but it's also up on the computer where I can do the advanced diagnostics that the Smartfield offers. In many cases, this doesn't prevent the patient from coming back. Oftentimes, we still have them come back in a month for a follow-up eye pressure check or an OCT or a repeat visual field test to confirm whatever defect we find. But most of the time, it allows us to at least better manage the patient, better make decisions right then and there on the spot. And we feel like it's definitely improved the care that we deliver here.
I agree. So while Dr. Hale, just so I can give you the technician perspective, while Dr. Hale has left the room and he's paged us, we have a paging system. We'll get the page stating that we need to do an on-demand perimetry. So we'll go clean the system really quick, get the patient's name in there. We tell the other technicians that we're going to be busy, we're not going to be available. We get another page stating, okay, I'm ready. We'll go in to grab the patient, we'll take them across the hallway, and we will go into the back room and we'll perform the test. Now this test is 3 minutes per eye, 1 minute explaining and getting the patient lined up. It's fairly quick. We save the exam room that they came out of, so we don't have to find another one later. So we take them back, we put them back in the same exact exam room, and we page the doctor and we say, hey, your patient's ready, we're done. And we already have it pulled up on the computer, we already have it printed out as well. And he comes out of the room and he knows exactly which room to go in. It works out very well.
And is that, Brandy, has that, and Jim, has that changed with COVID? Before, were you able to move patients in different exam lanes and different rooms and not necessarily bring it back to the same room? Is that a new procedure? Okay. Okay.
Yes, it was very different before COVID. So we were able, if we couldn't keep the room, if we had to get another patient in there, that was okay.
Okay.
We would just somehow notify the technician as they were coming out that the room was, had to be taken, or we need to take it, or we would take the patient, so they'd bring their stuff with them. But right now, with the way sanitizing works, we're unable to do that. And ideally, we want to put them back in the same room anyways.
Right.
So it just works out all together.
Right, right. And in terms of the workflow, being paged and bringing the patient in the room and doing the on-demand perimetry, there are no bottlenecks in that process. It seems to go smoothly with the fast testing and with the ability to run them through on the Smartfield.
That's right. It's very smooth now. At first, we definitely wanted the billing or the insurance to be checked before they came into the office, but Dr. Hale will touch on that later.
Yeah. Okay. Fantastic.
Yeah, I haven't been hearing a lot of description from the staff that it's slowing things down. I certainly haven't felt it myself. From a doctor's point of view, you're going to spend the time with the patient describing the visual field defect no matter what. So you might as well just get it done on that day, as long as your staff is prepared to kind of jump in. One thing I was just going to point out is that I've been hearing this from the staff that they really love this unit. From a COVID perspective, the lens just doesn't seem to fog up with our standard Humphrey. The lens is right there. It fogs up with the masks. The new unit doesn't. It's easier to disinfect. Flows just better. The laptop's actually portable, so you can run the machine at a distance. And I actually was so impressed by this, I took a couple of pictures. So I don't know if this is the proper time to show them, but I'm happy to.
Yeah, please. Go ahead and show that.
So
we
have some workspace challenges in our office, but like everybody else, we always feel like we need more space. This is kind of the corner we have the visual field machine stuck in, and this is in our special testing room. So as you can see, Brandy's here. This is just a model patient that we saw the other day. We snapped a photo because we thought it would demonstrate principle that we wanted to talk about. So Brandy's doing the visual field. She's right there. That's about 18 inches, 24 inches at the most. With the Smartfield, she's actually quite a bit farther away. Now we have to kind of move things around a little bit like Tetris in this room to do the various tests. But as you can see, she's got a laptop over there, you know, just kind of casually relaxed. She probably has a Mai Tai hidden somewhere over in the corner or something. She's at least 6 feet away from the patients at that point. And so we just felt like that kind of gave the staff some added comfort that they were safe when doing these tests.
Yeah,
So that's been a bonus for us
aspect.
as well.
Yeah, that looks great. Can you also comment on you know, I think early on, Brandy, you had done a comparison between patient comfort with the big perimeter versus the Smartfield. Can you comment on the patient's input?
Yes, I did. I did some research, you know, comparing the two because I really wanted this device in our office. And so with the Humphrey, I don't know, Dr. Hale, if you can go back to the other image for me. So with the Humphrey visual field, as you can see, she's pretty stiff and she has to go in there pretty straight. And there's a lens. She has to wear a patch as well. And I will tell you right now, the patients hate that patch. And there's a lens that has to go all the way to her eye touching. Otherwise, it'll cause a ring scotoma, which will make us repeat the test. And before we learned how to really determine what the test meant when it was printed out, we didn't know. And the doctor's like, hey, you know, this is probably from the trial and you need to go redo that. And so we'd have to redo it again. And of course, the patient would grumble because the test takes so long. So the test is taking, you know, 5 to 6 minutes per eye. And if they're missing a whole bunch of them because they truly do have a defect, then they, you know, they're going to be in there for about 8 to 10 minutes. Right. So with that being said, you know, just taking the trial lens out, replacing it, having them put it on the other eye, you know, they're tired by the end of this test and they want nothing to do with the technician. I can tell you that. And then go back to the other image, Dr. Hale, if you could please, thank you. So with this one, as you can see, she is leaning in to the machine, and the patients, I did, you know, a comparison, and I asked them which one they would like better, and they loved this one. They said they were more comfortable, they were leaned in. I wish I would have taken a picture. The trial lens is actually stuck in there, so it doesn't have to touch their eye. So they really enjoyed that. They liked that. They didn't have to wear a patch. It went faster. So even if they're missing a whole bunch, it's still 3 minutes per eye. So they just preferred this machine over the Humphrey. So and then 33% don't even need a trial lens at all. They don't need a correction. So,
right. Because of the target, right? Because the Smartfield has a distance target where the patient looks at, whereas mostly every other perimeter has a near target. So yeah, no, that's great, and I guess that's kind of the whole reason why the unit makes it on-demand perimetry possible, right? Whereas the other units, you know, where it takes a long time and it's more cumbersome with the lens and the eye patch and the 6 to 8 minutes per eye, you need the patient very refreshed. You need them not tired, you know, and so usually you probably for that previous the before methodology, it was probably best to bring them in on another day to schedule that.
Well, not only that, but we have a full schedule of special testing already. So we have our own schedule that we have for testing, and to be able to fit a Humphrey into the middle of a full schedule already was impossible. And not only that, our job is to keep our doctors on time. And if we're doing a Humphrey, they're going to get behind. And with this, they're not going to. If they want something, if they want this done today, they're still going to stay on time because it's so fast. And we're going to stay on time as well.
Good. That's important. Fantastic. Okay.
Yeah, so it's anytime we're going to bring in a new instrument, we want to create a new workflow that will work. And that's crucial for on-demand perimetry. You just have to be prepared for it. Brandy and I did quite a bit of talking and thinking about, you know, what we were doing before or at the time, currently, And we were looking at the amount of staff time it takes to arrange a visual field for follow-up. So we looked at all the staff members combined and how long it took just to complete that follow-up visual field a month later. And so, it's like 5 to 8 minutes with the receptionist, dodging the dental appointments, scheduling around the niece's wedding, whatever, trying to find a time to come in. So that takes 5 to 8 minutes. Patient goes away, they come back a month later, or at least 85% of them in our practice did. So the check-in process would take 5 minutes. It would take 5 minutes for the staff to create a new chart note, bring them back. And then the visual field test itself was pretty fast on the Smartfield, 3 minutes per eye. Double that or more on the other unit, but total staff time just to do a follow-up visit is 20 to 24 minutes minimum. And so we found that with on-demand visual field testing, we're looking at 8 to 12 minutes of staff time. It's just right here and now. The chart note is created. They don't have to redo that process. They don't have to schedule an appointment. They don't have to check the patient in. That's already been done. So we felt like that staff time we gained, those minutes, could be translated into helping the doctor be more efficient while this process is happening. So they put a lot of effort into helping keep us on time when we pull the trigger on an on-demand visual field test. So I think I was asking myself in preparation for this lecture, like, how do we do it? If I were going to tell my friends, like, this is what you need to do. I think for me, the key thing to make this work has been the moment I know I need a visual field, I notify the staff. On-demand visual field. I page them. I use whatever messaging system I have at my fingertips. At this point, actually, sometimes I go walking in the room and on the chart, there's a sticky from the staff saying, you're going to want an on-demand visual field on this patient. They see the FDT screener and they just know. But early notification is crucial because that gives them the time to go to the back, turn on the Smartfield, program the patient's name in, get ready to go, notify the other technicians that this process is going to be happening. So I think that's key. I then just, like all other communication with the patient, at the end of the exam, I tell them, hey, I've identified this risk factor. I need to order another medical test. This is why. And we're just going to do that now. And so I page the technician, they walk in, I leave the room. And so at that point, Brandy and her team would take over.
That's right. Yeah. And that's when we would, go, like I was saying earlier, go sanitize, put the name in, put the birth date in, all of that's taken care of before we even go grab the patient.
Right.
And we already know, so as you probably know, patients want to know, well, how much is this going to cost me? So we already have also, which Dr. Hale will touch base in just a moment, we also have the insurance written on the flow sheet. So I'm able, and all of my technicians know exactly how much one costs. So we can tell them how much it's going to cost, because you don't want to waste your time talking about cost. I mean, this is about your eye health. We need to get going. We need to go back there and get it done. And then, like I said, we page him. That's our system. We page. So it works well with us. And we put him back in the exact same room. It's over within 6 minutes. It's been great.
Yeah. No, it sounds like you've created a very efficient workflow. So that's fantastic.
Well, it definitely works. The machine's fantastic, and just the speed of it makes it possible. So it doesn't always eliminate that follow-up visit, that 1 month follow-up visit. Oftentimes I still need to bring them back and do more testing like an OCT, repeat visual field, and IOP check. But every once in a while, it just answers the question and we don't need to do another, potential COVID exposure a month down the road. So it's definitely got numerous benefits that we haven't even really begun to touch on yet.
Right. Yeah. Who would have known when you got it, 8 or 9 months ago, that the whole world would change and that the whole process and disinfection and, do you use an eye patch or not, and what happens when a patient potentially coughs or sneezes into a bowl perimeter, the whole disinfection process, the enclosed perimeter of the Smartfield is a real solution for you, I believe. So
yeah,
glad to hear that.
Definitely it is. I prepared some case examples if you guys would be interested in seeing those. I didn't really do them like an academic case presentation. Mostly I wanted to work through it like as if I'm doing it on-demand Premetry. The Smartfield can print out a paper print that looks a lot like what some people would be used to with the Humphrey. So when I walk in the room, I have that already, but it's also up on a computer screen. So I wanted to spend just a few minutes also showing kind of the differences between the paper printout, which is kind of like your old flip phone, you know, back in the 90s, versus the computer version where you can, like, you know, smartphone it up. It's pretty impressive technology. So if it's okay with you guys, I'll jump into that unless there's anything to add before we go on.
No, it's fantastic. So you've got a couple slides already showing the devices, and also Brandy already gave us some input. So yeah, let's go right to the case examples. That's a good way to go.
All right, so this is a patient that I saw, and I wanted to just kind of introduce the Smartfield printout through this patient. So she ended up having glaucoma. She came in for an exam. The FDT was abnormal. The eye pressure was a little bit elevated, and she had larger than average CD risk ratios. So I wanted a visual field. I knew I wanted a visual field. And so we went ahead and just jumped right in and did an on-demand perimetry. So this is the left eye. And as you can see here, it's pretty clear. Nothing really going on. It kind of looks like a standard Humphrey printout with, you know, the kind of similar data placed similarly. It's Oculus's own creation, but it seems very comfortable and familiar. So that was the left eye. The right eye, there's our inferior arcuate. And so that pretty much at that point confirmed the diagnosis of, you know, likely glaucoma. This case happened way back in the beginning when we first got the Smartfield. And so I wanted to bring the patient back and kind of learn, you know, how to observe the differences between what I was used to, the old version, and the Smartfield, the new version. So in this case, I'm going to show kind of the follow-up 1-month visit. I did a repeat visual field to confirm the defect. So here's the right eye, not much to look at. We do have a lot of false positives, some fixation losses. Left eye, it didn't really show anything. And that was a surprise to me. So, you know, again, false positives. The technician actually came out on this one and was like, you know, I don't really feel all that good about it. The patient was kind of moving around. So I kind of like being able to see stuff. So that's kind of what this looks like. This is kind of a side-by-side view. So you can see kind of the standard view that you might show the patient, some of the raw data. You know, across the middle, it's similar idea. Down here, they've Oculus has added the Rossini glaucoma staging system. So this person came in at a stage 2, which is actually helpful for charting and coding for ICD-10 and some of the new requirements for billing. So that's I've been utilizing that a lot more these days.
Jim, in this, just a quick question on that case, and if you go back to that, was it? It looks like the patient's numbers, you know, the fixation losses and the false positives were a lot better on the Smartfield test, and that in terms of the Humphrey result, that the results were quite unreliable. Is that in fact what you had said about this?
It's kind of
Case?
a, you know, a
And it's because
standard.
the time was too long, that long testing, or any idea there?
Yeah, it's a great question, and I don't exactly know how to respond. It's been, you know, about a year ago since this occurred. It's something we've all seen, we've all experienced it. You know, it's part of the nature of taking this very subjective test.
Yeah,
We've been finding less of it these days by quite a long shot. Yeah.
great.
Can I just say something about the Humphrey and the fixation losses?
Of
So
course.
with the Humphrey, the fixation that they have to look at is a lot smaller. And so, and with the Smartfield, it's bigger. So we do find that even if they're not looking away, it's saying they're looking away. And they do like to wiggle and move around quite a bit in the Humphrey, and they don't wiggle or move around in the Smartfield because their head is, you know, it's forward, it's
Comfort,
staying put, and it's faster. So I would like to put some input about the two machines and the comfort level and the fixation.
Yeah, great point, Brandy.
Fantastic.
All right, well, I'm just going to keep trucking. Patient 2, 63-year-old Caucasian male, ended up having glaucoma. That's the punchline. It was kind of the standard scenario. The FDT at the visit was abnormal. Eye pressure, 23 in the right, 26 in the left. The CDs were small, 0.1 and 0.15, and the nerves just looked small. But because of the abnormal FDT, which is shown here, I decided to pull the trigger on demand perimetry. So the right eye came out looking pretty decent, not a lot to look at, maybe a little something here or here, but overall not super impressive. And the left eye looked like that. So it's kind of another one where like immediately I've got an answer. I know what the situation is and I know that we need to take action. So this is another case that happened early on after getting the unit. And actually that was done by design when I was preparing these slides. I wanted to find patients where I could show both. So, you know, this is the 1 month follow-up. We did a visual field to confirm the defect. And it looks kind of like we're used to seeing, maybe a little less obvious with this instrument, but kind of similar. So clearly there is a problem. We did an OCT. The nerve is really small for those people that are used to the Zeiss OCTs. The optic nerve is very small. If we look at the side view of the nerve, it's just kind of a crowded nerve. And as we all know, that just makes the diagnosis of glaucoma difficult. It's really easier, a lot easier when you have a great big nerve and a big CD. When you've got these small nerves, it's a lot tougher. But the system we have in place came through for this patient. And as you can see, thinning superior and inferior both eyes. So glaucoma treatment commenced.
Great
Just kind of
case.
going back to the Smartfield to show that again.
Yep.
I wanted to jump into some of the more advanced diagnostics. So this is the standard paper printout, but as I mentioned, this is kind of the flip phone version. The smartphone version, it's like it's on a computer. I just click buttons and I just kind of rapidly go through these different settings to look at different aspects in greater detail. I love this 3D map. This really resonates with patients to show a defect and highlight it. This is that Brucini glaucoma staging system I mentioned. So it's at the bottom of the printout, but it's also on the digital form that you'd see on a computer screen. In this case, the patient was kind of like a stage 3 glaucoma in the left eye. So just kind of wanted to show off the fancy Oculus technology here before we move on to patient number 3. Unless there are comments or questions.
Jim, did you say that the patients that the color scale of the defect really resonates with them as well?
It
Yeah.
does. I mean, when you show a patient something like this, you know, they see this black spot that you can tell them it's a visual field defect, it's visual field loss, and I think they get it. But I just find that especially in the more subtle cases, this seems to show it better. Showing them the statistical analysis down here doesn't really necessarily resonate with a patient like a true color picture would. And there are a couple of subtle cases coming up. So I'll show you kind of what I mean by that in a second.
Okay, fantastic.
So case 3, this one was just super confusing and I didn't quite know what to make of it. So we've all been there. You see a patient, there's some stuff going on and you're just trying to figure it out. So this was a 57-year-old Caucasian male. FDT was abnormal again. There was a little bit of NS and PSC going on. IOP was relatively normal, 17, 18. And again, we had kind of small CD ratios and there was an old BRVO observed in the left eye as well. It was inactive. So the FDT kind of looked like this. I had them repeat it, or actually they probably just automatically repeated it. So we pulled the trigger on the on-demand visual field testing and we got something like this. So right eye here, this could be a nasal step. This could be neurological, not quite sure. Left eye, that looks a little bit more like a standard glaucoma. Again, a little bit confusing, just not quite sure. I felt like I needed more data. So this was again early on when we started using the Smartfield. So we brought the patient back a month later. This, by the way, is a side-by-side comparison that I threw in there just as a demonstration of kind of how you can look at things side by side on the computer screen. So they came back in a month and this kind of freaked me out. It looks quite neurological. Didn't quite know what to make of it at the time. Left eye here, this looks a little more glaucomatous, but that could be neurological as well. So still a little bit stumped on this case. We did the OCT and a slightly smaller than average nerve, thin superior and inferior. little bit thin nasal here on the nerve fiber layer. What's interesting is this side profiled view of the optic nerve head. And so this patient actually ended up having buried drusen. And I don't have a picture of it. I can't really show it to you, but my best estimate of what's going on here is that there's buried drusen. And as we all know, that can put people at slightly higher risk of glaucoma in the same eye. So there might be some glaucoma. I'm still following this patient to this day, and we'll see what happens over time. But as it's been so far, it's been non-progressive. So we have not started glaucoma medications. But
So
we're
when you
certainly
say
ready.
when you say buried drusen, you mean optic nerve head drusen?
Buried drusen in the optic nerve head, yes.
Yeah. Okay.
Fairly common condition, and it's just one of those ones that's kind of tricky.
Yeah.
So hopefully that's all it is, and we don't end up needing to do anything more. But it was certainly helpful to have the information right off the bat so I knew how to prioritize things.
Yeah.
The next patient, so this is the one where I put a bunch of different slides in, and I'm kind of going to try to go through it like I do in the exam room with the Smartfield program up on the computer. Another person that ended up having glaucoma, 63-year-old Caucasian male, again, the abnormal FDT, slightly elevated eye pressures, CD ratio, 0.6, 0.7 in the right, 0.65, 0.75 in the left. A little bit of advanced information at the subsequent visit. I did pachymetry, and it ended up being pretty thin corneas, 480 on the right, 460 on the left. So the adjustment factor recommended by my software is +4 millimeters of mercury, +6. So these eye pressures were probably actually 28, 29 at that first visit. I just didn't know it at the time. The patient came back a couple weeks later. Oh yeah, I forgot to mention, this is the FDT that triggered the test in the beginning. That just looks like standard glaucoma there. It was repeatable twice. So we pulled the trigger on the on-demand, which ended up looking like this. So this is the paper printout that I grabbed when I walked into the room, side by side, arcuate defect here, Brucini, gray, stage 2, almost 3 in the right. Left eye a little more subtle, but it kind of looks like a nasal step there. Didn't quite make the Brucini scale, but it's right there on the edge. So that looks like glaucoma to me. So in this particular case, again, it was early on when we started the Smartfield. We went ahead and brought them back to look at a repeat visual field to confirm the defects. This is kind of how it looks on the computer screen. These are screenshots that I clipped, but it's kind of how it looks on the screen when you want to get a little more in depth. So here's the paper. I then look at my computer monitor and I've got more of these advanced diagnostics. This is kind of one of those 3D views that would resonate with a patient. That's pretty obvious what's going on there. There's a defect in the vision. This is the right eye, kind of a simple raw data view, arcuate defect view. This is a color map that some people prefer to use. I don't use it a lot, but I wanted to show it. And then again, this is that 3D view that just makes it really clear where the problem is and what's going on. So this was all available at the time. And as I sat there with the patient, I looked at the paper, I pulled up the software, and I just clicked buttons and kind of scanned through these different views to get all the information I needed to make an informed decision on the spot. This is actually another view that is presented in the software that kind of predicts what the nerve fiber layer should look like when you do an OCT. And this is kind of a structure function view where it shows there's a problem with the function in this area, and the structure of the nerve fiber layer might end up looking something like this. Helpful when you're going to take a look at somebody's optic nerve to kind of look at what the software says. Hey, there might be something going on up here and down here. I just wanted to show this as something that you could also click through to gather more data at the time when the patient's there on that same day as their comprehensive exam.
Jim, question on that. Did you ever verify kind of that path assessment versus what happens with the OCT, or a few times, or?
I did, and generally they're really, really close. In fact, I'll show an OCT on this patient, and you know, it's never a dead ringer,
Right.
but it is usually very, very close. And I kind of feel like I have an advanced view of what it's gonna look like. The way that I use it usually, though, is just I'm trying to
Yeah.
confirm that the defect on the visual field matches the defect on the OCT. And
Right.
that's confirmation that we've got a match. It helps confirm the diagnosis. And so it's useful in that category for
Yeah.
sure.
Yeah. Do you have sort of a theory then? I mean, if you look at this and then you're having them come back for the OCT a month later, you know, do you kind of have this as a little bit of a preview of what you think might show up on the OCT, or just
Well, it does function that way in clinic. You know, I'm
yeah,
having to be efficient because I've just added a couple minutes to my schedule.
yeah,
So I glance at it typically, and then I look at the optic nerve and I look for a wedge defect in their fiber layer in that area. It oftentimes helps me find those little nerve fiber layer defects that would have been difficult otherwise.
interesting. Thanks.
Yep. So when the patient came back for the OCT a month later or so, it's kind of what you'd expect to see. So kind of pointing to those same areas up and down. Then superior and inferior, both eyes. Relatively normal nerves, maybe a little larger than average, but this kind of confirms that we've got a loss of superior and inferior nerve fiber layer, and it matches the visual field defect that we're seeing with the Smartfield as well. We did a Humphrey, which looks like this, and so it's kind of what you'd be expecting to see. Again, similar viewpoint. My business partner loves the paper view with the Smartfield. I kind of prefer the computer view, but we use them both.
Yeah.
I wanted to put them side by side to just show again, they're pretty similar, same idea. It looks maybe a little more severe here in the Humphrey, but with all the advanced diagnostics that we get in the Smartfield, it becomes very apparent that something's going on here. That's
So
left eye.
the transition from the printouts was not too challenging for you to go from the Humphrey to the Smartfield.
Very, very short learning curve.
Yeah.
The software has a lot, so like so many things, if you really want to dig in and understand it, it takes a little bit of time, but the basic stuff like this printout, it's like, you know, few patients and you got it down.
Yeah. Fantastic.
This is kind of like some of the Smartfield advanced diagnostics that
Hmm.
match. So this is what's on paper. These are some of the shots that you get by just clicking through the computer software.
Yep.
So this is the right eye, a little more advanced visual field defect. I felt like the Humphrey may be underestimated a little bit. Again, advanced diagnostics on top of it. So those are my cases. So hopefully that kind of illustrated how we go through the process and kind of what it looks like as we think it through on the spot and a month or so later when we often bring people back anyway.
Right. Right. Good. Um, anything else to add, Brandy, from the technician's perspective? Or
Yes,
should we
I
go
would
back?
like to add that your technicians can do anything, so utilize them. If you spend the time with them, like Dr. Hale has spent with me for the last 5 years, going over the test results, what do they mean, how to read them. I'm able to go in before he even enters the room and put the diagnostic in there. So all of the analysis, so if the FDT defect, I could put the diagnosis in for him. And so having that ability to do that, and he walks in and it's already all charted in there for him, has been great, because then he can just be like, oh yeah, okay, let's do it on demand. We already know that it's going to happen. So utilize your technicians. They are smart. Spend the time with them,
Yeah.
go over the test results with them. 3 out of 4 of my technicians know how to read a visual field defect, and they
Great.
can put it in the chart for the doctor.
Great. Great. Okay. And then in terms of on-demand perimetry with the Smartfield, pretty much 100% of the time you're able to do that. I mean, right there in with that first visit.
Oh
And,
yeah.
and I think patients understand that now, that they don't necessarily want to come back, right? They want to, and you want to get them quickly through the clinic, and they also want to
Yeah.
quickly get through and not come back for another appointment, right?
Right.
Yeah, anything we can do to simplify the process, they
Right.
appreciate it. They're, in many cases these days, they're a little nervous being there anyway, and so anything we
Yeah.
can do to make it a one-stop scenario,
Right.
I think we should try for sure. Um, I back to what Brandy said, I'm super spoiled. I've got great technicians. They care, and we've put a lot of time into them. And so when we were thinking through this lecture, talking about it, one of the things that we wanted to present is kind of like, okay, if there's anybody out there that wants to do this, what are the steps that it would take? Like, what would you
Yeah.
have to do to make this happen in your own clinic? And so Brandy and I brainstormed a little bit. And so a couple of things, I don't think it could be done with a slower perimeter. We're really, really happy with the speed of the Smartfield. And so from that perspective alone, we already had 2 fully functional visual field perimeters. Adding a third one, this process would not have been possible without this technology. So that's one of the number one things on getting started with this process. It's got to be fast.
Right.
Um, yeah, another thing is that the technicians really need to be trained to jump to action when an on-demand visual field test is ordered. So this is just training, and hopefully with some enthusiasm, your technicians would take right to it. When the on-demand perimetry is ordered, they need to get the machine up and running. They need to plan how to continue the clinic flow with the patients that are there, avoiding delays. And they also need to be there to help facilitate the doctor staying on schedule. I basically walk out of the room and look for Brandy or one of the other para-optometric technicians, and whichever direction their finger's pointing, that's the room I go into. And so I'm just really fortunate to have them there kind of steering me that way.
Right, just steering you from room to room, and when they're done with the on-demand perimetry, they bring them back to the same room, and then you're going in there and you're reviewing the results with them and coming up with the diagnosis, etc.
Exactly.
Okay, good.
Usually, I'll comment that usually the staff actually stick around for that. So they'll stand there and just listen. So I'll say to the patient, it looks like we've got glaucoma. We're going to start a medication. I'll see you back in a month. I'm going to order an OCT and a follow-up visual field, or maybe electroretinography, whatever it is. I just tell it to the patient. My staff write it down. They go in and type it into our medical records so that I can just immediately move on. So this is kind of just along the lines of training again, work on the flow, get the team on board, and it is definitely doable.
Right, right. So you need a fast perimeter. You need the staff, which is motivated and inspired and knowledgeable, and then in terms of what you were talking about before, medical billing, you need to also check that I understand the insurance beforehand to know whether that test would be something you could do.
Yeah, so that's number 3 on my list of,
Okay.
to-dos to get this going is
Yeah.
like, if you're not already doing it, training your front office staff to check medical insurance eligibility
Yeah.
and deductibles on every patient in advance, it's super helpful. And I know for a lot of clinics that might be too much. They don't have enough staff, whatever it is. If that's too much, maybe begin by focusing on people over 60. So what I've found is that having that data at my fingertips helps me in an on-demand situation. It helps me even if I were in the old model where we would just schedule them back in a month. The patient's going to ask. They're going to ask what the test costs. And so having that information at your fingertips is super helpful. I also find that it kind of lowers my threshold a little bit. Like if I'm on the borderline of ordering a visual field, maybe they need it, maybe they don't. Just kind of knowing that they've met their deductible is helpful. It gives me some
Yeah.
reassurance that we're not going to have a big barrier when the time comes. So
Right.
I think that's been highly valuable for us.
Fantastic. Jim, the other question I had was before you had said that about in the past about 15% of the patients did not show up to the follow-up visit like a month later. Do you think that number is would be potentially worse now without on-demand perimetry just because of the uncertainty of the patient and like in this unusual times,
Yeah,
everything going on?
that's a great point. Like, you know, seeing what's happening with some of my colleagues across the country, I can't even give 100% guarantee that I'm going to be here in 2 weeks. You know, I could be in quarantine at the drop of a hat. Hopefully that won't happen to
Yeah,
any of us. But if it did, I may not be here. And I certainly
yeah,
wouldn't want that patient's diagnosis to go another month or two if it were something like
right,
glaucoma with the high eye pressure.
right,
So doing it right here and now benefits everyone on a number of levels.
right. And yeah, and if that patient somehow was positive and they came in for the follow-up visit, obviously that would not be ideal either. Exactly.
Right.
Okay.
We've just reduced our exposure for sure.
Yeah. Yeah. Okay. Any other to-dos to get on your list to get going with on-demand perimetry that you or Brandy recommend besides those three that you just mentioned?
Well, the fourth thing I put on there is just kind of like next level stuff, like
Yeah.
really for so many of us that are blessed to have these amazing technicians, taking it to the next level is empowering them to help you be more efficient. And that requires giving up a little bit of decision making to them. So when you walk into the room, if you've trained your technicians to just glance at a visual field and know what a midline defect looks like, or so many other things that they can learn easily, if they're prepared to alert you, if you're open to listening to them,
Mhm.
that's
Yeah.
the next level, because that by itself can save a ton of time and facilitate on-demand perimetry amongst other benefits.
Yeah. That's fantastic. Seems like the real team approach there at Valley Eye Care.
Most definitely. Well, yeah, and thanks to Brandy, my clinic manager, who is really leading the
Yeah.
charge there.
Right. Right. Okay. Well, we have some questions. If you're ready to entertain a few questions, we have some questions from the audience.
Absolutely.
Um, and the first question, let's see, I might choose this for maybe this for Brandy. Brandy, you might be in high demand here. If you aren't using an eye patch, what are you using to block the patient's other eye?
Oh, that's a good question. So, Dr. Hale, would you go to the slide that shows the Smartfield for me? You can
Way
work a
back to
little bit
my
here, sorry.
I'm sure there's a quick button to get back here, but I'm not a professional lecturer, so let's just do it that way.
Okay, so as you can see, the patient's face, by the patient's face, there is a plastic piece that comes out,
Yeah.
and that actually helps with not only lighting, but it does block the other eye from seeing. So there's these two chin rest dips. I'm going to use my hands to talk, because I always do. No, I'm not Italian. I just do.
Yeah.
So they dip down, and then they're going like this, or the other way. And that blocks off the other eye, and they can't see. I mean, we put it to the test, and I've taken the test myself. Williams performed it on me,
Yeah.
and
Yeah.
you don't need a patch. You don't even need the lights to be off. So that's
Right.
also another great thing as well. So their eyes already singled out. There's no need for a
Right.
patch.
Right. Those translucent eye shields come with the Smartfield. So
Yes,
those are,
right.
can't see through those. So those take the place of the patch. Exactly.
Mhm.
Okay. Good. Um, are there situations where you use the Smartfield primarily? If so, which exams are you performing?
That's a great question. So I just really touched on glaucoma today, optic nerve problems, the varydrusen, et cetera. But I mean, the on-demand perimetry is useful in so many other categories. So ptosis, if the patient complains that their eyelid's droopy, I'm going to make a referral to oculoplastics. I'll just on-demand it right then and there. It makes the referral process more smooth for the patient. Plaquenil, high-risk medications, that 10-2 we're supposed to do. There's a on-demand option in the perimeter for that. There are just many, many, many scenarios where this is helpful and useful, and this is our go-to instrument for all that stuff.
Right. Right. Can you comment on the fixation control in the Smartfield? I know there's two types of control. There's the blind spot monitoring where, every once in a while during the test, it goes back and it checks the blind spot. But there's also central fixation where it's checking centrally. Is there a preferred control method in your practice that you use with the Smartfield?
That's a great
Is
question.
it central? I think it's central. I think we set it to central when we were there.
We did.
It is.
We haven't played with that setting in particular. It's just, I mean, it just worked like a charm from the start. So that's one of those areas where I could probably dig deeper and
Okay.
experiment. I just haven't really felt the need because it was pretty seamless right from the start.
Yeah.
Fantastic.
Fantastic. Okay.
It is set to central. Correct.
Okay. You mentioned that you need to use trial lenses. I didn't quite understand that. How are you using trial lenses less often?
So I did a study where I took, I think it was 100 patients, William? 100
Yeah, I think
patients.
it was a little bit more, but yeah.
Yeah, so I took and I actually dug into their manifests and determine if they needed a correction or not. If they needed a distance correction, then we would correct for it. But near is not necessary. And if you think about how many people you're doing a visual field on, they're older, right? So they need a near correction. Well, not with the Smartfield. So it decreased the trial lenses that you need by 33%. So yeah, you still have to have a distance correction, but that near correction goes completely away. With the Humphrey, you have to have not only a distance correction, but you also have to have the near correction. So
so that's a difference of a third fewer patients needing a trial lens on the Smartfield. Okay. That's very
Yeah,
clear.
and we like if a patient needs a Smartfield and they have contact lenses that are the proper prescription, their contacts are in their eye, they just go do the test. It's set at distance. So if they've got an adequate distance prescription, glasses or contacts, they can just step up to the machine, put their head in, and they're off and running without a trial lens.
Right.
I didn't even take that into consideration when I did the study.
Yeah, so there's more.
Yeah,
we have to redo the study.
we do.
Do you ever screen patients with the Smartfield, or is all of your screening done with the FDT?
So we use the FDT as our screening instrument, but it's really just for clinic flow that we do that. If we needed, if we had the ability or the need to just have one instrument, this would be it because it can do everything. Our special testing room, which you see on the screen there, it's in use, half the day or something. I mean, they're always scheduling patients. And so using the Smartfield as a screening tool would get in the way of patient flow out in the clinic because that's performed in kind of a pre-testing room. So we decided to just continue with our FDT, not utilize this as a screening tool at this time, and keep it in the back in the special testing room where it's a little closer to the clinical setting, a fewer steps for the patients to walk to do the test on demand situation.
Yeah, you pretty much put it as the focus of on-demand perimetry. That's clear.
Yep.
Okay. Someone was asking whether they can print out the color maps, and that's definitely possible to print out the color maps. I don't know if you're printing it out. Obviously, that uses a lot of color ink, but to print out the color maps, that's definitely possible. If you need to and you want to use more colored ink, we'll tell you how to do that.
Yeah, well, I wouldn't. Yeah, I'm sure there's a way to do it. I haven't really pursued that simply because that creates more work. It's traffic for my staff. They've got to scan it in. It takes up more space in our server. It might be really valuable, to give to a patient if you're doing a referral or something.
Right.
If I want it, I'll just screenshot it and save it as a JPEG or a PDF, and they can scan it from there. And in fact, we don't even have color printers in our clinic simply because we don't want to deal with that. I guess for the OCT we do, but I like just having it in the computer. It's there anytime I want to see it. I flip on the machine. A minute later, it's booted up, and I look on the computer, and I can pull up those same maps.
Right. I guess the integration of the Smartfield and the adoption or the creation of the on-demand perimetry really set you up for the pandemic, right? And basically having those patients not have to come back. obviously patients love that. The practice loves that, right? And you've freed up a lot of extra follow-up visits that you can have for new patients or for regular patients as well, right?
Oh, yeah.
So that's probably been the whole efficient workflow has really been streamlined as a result of that.
Yeah, that's a side benefit we didn't really even anticipate. We're booking out a ways, and every appointment is crucial at this point. So,
Yeah,
in clinic earlier today, I did an on-demand perimetry and was able to not have to bring the patient back. So, in those cases, when it works out that they don't have to come back, it's definitely a benefit. In many cases, they still need to come back at 1 month,
yeah,
but at least it's done with more thoughtfulness on our part and more information on their part. If you do diagnose glaucoma, you're still going to have to check the IOP. Probably, gosh, if
yeah.
there were a way I could figure out how to do on-demand OCT, that'd be fantastic, but
Yeah,
we're not there yet. So, yeah, they're
got
still
it.
going to be coming back a lot, but even if
Yeah,
15 or 20% of them don't come back, it's a benefit to everyone.
right, right. Okay, a few more questions. You seem to use the FDT as a test to alert you for a potential problem. Can you comment on this?
It's a pretty decent screening tool. Like so many, perimeters, there are some false positives, probably a little higher maybe on the FDT. And those are the ones where on-demand perimetry is particularly valuable. You get a false positive that looks like a nasal step. You tell the patient, oh, you might have glaucoma. They go home, they wait a month, and they Google it every single day, and blood pressure goes up. And, if you can do an on-demand perimetry right then and there and say, oh, you know what? The machine was wrong. Look, you're crystal clear, nothing to worry about, see you in a year. That's a pretty huge victory.
Yeah, yeah, that is fantastic.
We do use the FDT as one tool in our arsenal to find potential problems. Yeah, for sure.
Right, right. Another question here. I think you talked about ptosis testing. Can you compare the ptosis testing in the Smartfield versus what it was previously in the Humphrey system?
Yeah, I can, because I love the Smartfield when it comes to ptosis. So with the
Right.
Humphrey, they were, as you know, the Humphrey, you're missing a lot of the lights with speaking longer. So I
Hmm.
did do a study on that, and it takes about, even with the eyelid not taped, it takes about 10 minutes.
Wow.
And that's a long time because they're missing all those lights, and you're just sitting there going, oh, come on. And they're probably thinking the same thing. And then you're taping the eyelid. So you're doing the test 2 times per eye.
Yeah.
With the Smartfield, even if they're missing them, it was like a minute and not,
Right.
a minute and a half, which I absolutely loved. And you know that because you were here, and I was just completely shocked
Yeah.
of how
Yeah.
fast it was. And the patients like it a lot more too. So.
Right. So another example then the ptosis that you need to do on patients ptosis test you're also doing on demand, whereas in the past you had to have them come back
Right.
for the whole procedure. Okay.
Mhm.
Got it. Makes sense. Okay. Uh, okay, we got a comment. Wouldn't OCT on demand actually be faster than Premetry on demand? Is the question.
Well, that's a great question. I guess I'll have to go workflow that out. I'll count the minutes. I don't know. I'd have to look into it. If you look at the picture on the screen, you can see that our OCT unit's over in the corner there. And we are a busy clinic that is a little bit undersized, actually fair bit undersized, just space-wise. We're
Yeah.
just a little landlocked here, so we can't really expand. So we've had to really kind of adjust things in the clinic to make it work. So I suppose the patient could just swing from the Oculus over to the OCT. Well, you know what, Brandy, why don't we try it out? We can let them know next round.
Yeah, the only thing I would say with the OCT is when they are older and and they're not looking where they're supposed to be. I mean, there's a whole bunch of problems. They have to bring another tech in. They have to hold their head. So, I mean,
Right.
with the Smartfield, I don't have to do that. I don't have to bring another tech in if they're a problem child. But with the OCT, I would. So, I mean, of course, if they were younger, yeah, I could, get an OCT done fairly quickly, but not if they were an elderly patient and there was cataracts and, other issues that are going to be involved with that. So
Right.
it's hard to see sometimes with the OCT. So, and, 4 pictures per eye as well. I mean, Dr. Hill, you like to have your pictures.
Yeah, I do. So
Yeah.
we're doing optic nerve scans, we're doing radials, and we're doing macular cubes so that we can get, the ganglion cell layer and everything. So OCT does take a little while. But Brandy, let's talk about testing it out. Maybe over the next couple of weeks, we could do a couple and just get an idea. And then whoever was thoughtful enough to ask a question, my email, I'll put it back up on the screen. And if it's of interest to you, just shoot an email and we'll talk about it.
Yeah, great. Okay, let's see, we have maybe 1 or 2 more questions. Okay, I think you already answered this. The question is, Brandy, do you find patients have an easier time using the Smartfield? Yes, you did say that. It is easier. Other part of the question is, are there any tips you have for technicians who are working with this device to help with patient instructions and speed of the exams?
Yes. So you'll want to, I'm so used to knowing what it looks like because I do dry eye as well with the Oculus.
Mm-hmm.
So you're going to want to get familiar with, and Dr. Hale, I don't know if you took a picture of what it looks like before you even start the test, but you want to be familiar with the technology. So you're going to want to enter the patient before you even take the patient back there. You're going to want to clean everything off. You're going to want to have the trial lenses ready before you. So if they need a trial lens, you're going to want them ready and laid out for you so you can easily put those in. So you're going to want to think ahead. What do I need to make this faster? And when you're explaining the test, it's a lot easier to explain than the Humphrey is, I feel, because you're putting their chin on the chin rest, you're having them lean forward, they have their button. There's these 4 lights that make a diamond shaped when it's central, and they look right in the center of those 4 lights, and then they push their button every time they see a light pop up. So it's a very quick, easy explanation. You start the test and off they go. I tell them when they're halfway through, even though it's 3 minutes per eye, you switch eyes, it's 3 minutes, you're done. You take them back to the room. So I hope I answered your question.
Yeah, no, you did. No, you did.
Well, keep in mind also that you're typing on a laptop or a keyboard and it's fast. It's not like you're pushing this pressure sensitive screen and the delay and the difficulty that brings around. So it's fast in my experience.
Yes.
Right. Okay, well, that is pretty much a wrap. So Dr. Jim Hale, thank you so much for your expertise, and Brandy as well. Thank you for your technician's perspective. It was fantastic. We have Dr. Hale's email address on the last slide here. So if you want to reach out to him, please note that. And if you have any questions directly to Oculus sales and service about the Smartfield or about any of our products, you can see our phone number and email address there. Once again, everybody, thank you so much for your attendance. Dr. Hale and Brandy, thank you too. And everybody have a fantastic evening.
Thank you so much. Take care.
Thanks. Good night.
Night.